boundaries are very healthy and very important. And first and foremost, yes, your patient, but also yourself. Are you safe? Are you able to safely do your job and perform the functions of your job, assessment, all of that in this space? And if not, that needs to immediately get shut down, whether that's bringing in your manager, whatever you have to do, just not being afraid to make a big deal.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
This week on First Case, we speak with Michelle Lemmons, clinical educator in the OR at Key Surgical. Michelle has over 10 years of healthcare experience, including admissions, OR, acute care, post-acute care, transitional care, and long-term care. She also worked as a scrub nurse and circulator for the CV thoracic and general team at the University of Minnesota Medical Center and is passionate about nursing, leadership, healthcare, and individuals using their strengths to support teams and realize their full potential. And there it is, right there, Jeremy, talking about individuals using their strengths to support teams. And today we're going to talk all about disruptive behavior in the operating room. And honestly, the kinds of behavior that we're going to be talking about, it doesn't just happen in the operating room. It happens in all walks of life and all kinds of professions. But that's what's going to make this topic so much fun, I think, today with Michelle is she's got some great programs that she does with Key Surgical on this topic. She's very knowledgeable. She's done the research and she's worked with teams to help improve, that culture in the operating room. So I'm excited. I wonder how much we'll be able to pull some stories out of her, though.
Yeah, I think that's, looking back on my days as a manager and a director in the OR, this was one of the subjects that was always very challenging to deal with in the OR is disruptive behavior, whether it was staff to staff or surgeon to staff or anesthesia to CRNA. I mean, it just comes in so many different forms. And, I think that it's a big part of the culture shift that needs to take place in the OR so that we do make our ORs safer and more centered around patient care.
All right. Well, I'm excited to get into it with Michelle, and we're going to be right back after a short break.
You're listening to the First Case podcast.
Joining us now is Michelle Lemmons, clinical educator at Key Surgical. And Michelle, welcome to the First Case podcast. Really appreciate you joining us for this interview.
I'm really excited to be here with all of you. Thanks for having me.
So it's going to be an interesting conversation because a lot of times when I'm talking in the industry, we're talking about innovators and disruptors, but that has kind of a positive connotation. And today we're going to be talking about disruptive behavior in the OR, which has a little bit more negative connotation, but we're also going to talk about some best practices and how to deal with that. But I think even before we get started, if you could just give everyone a little bit of your background and your experience in the industry before we get started.
Absolutely. So I have been a nurse for a little over 7 years now, kind of with a varied array of experience. I like to communicate it as the entire experience that a patient would ever take. Admissions, surgery, acute care, post-acute care, TCU. I've done a little bit of everything. And for my OR experience was at the University of Minnesota on their CV thoracic general team. And currently I work as the OR clinical educator at Key Surgical.
Yeah, you have a great team of educators there that you work with. So I'm sure you enjoy your work. And I want to talk a little bit about, well, set the table, I guess, for the conversation around disruptive behavior and your personal experiences. Let's paint the picture here and have you tell us some stories where you've had to face disruptive behavior.
Yeah, absolutely. I think I love the word disruptors. I'm all about it. I think disrupting things is really good. Even gardening analogies, you have to disrupt the surface in order to plant seeds. So this is how we cultivate growth and change things in our industry. So I think some of the things that come to mind with disruption are, of course, both good and bad, and then the reaction and responses to that. So one of the first things probably that comes to mind is I had an OR manager kind of tell me once, well, we used to do it. I used to have 20 patients. I used to do this. And in the OR, we used to do this, as if to belittle some safety concerns that some nurses were coming forward with. And so that disruptive response, fortunately, became a team of nurses who decided to proactively make the safest choices for their patient in order to get the policies and procedures changed.
So, I remember back when I started in the OR, one of the challenges that I think I faced as a new nurse was that kind of hazing mentality, which is very disruptive, especially when you're trying to gain new employees into the OR.
Yep.
Have you seen that? Is that still out there?
Absolutely. It's actually a point of, there's a great conversation that's happening and research that's happening. A couple articles that I've read recently, they surveyed about 200 nurses, and 72% of the people that they surveyed reported that they had experienced bullying within the last month. And over 21% actually reported that they experienced bullying daily over a 6-month period. Especially we see this for new nurses. For whatever reason, this Nurses Eat Their Young, which I'm not to plug what I've done, but it is a very high passion of mine. I did a webinar called Nurses Eat Their Young because they're starving. And so from my perspective, this bullying mentality comes from nurses not having access to what they need, not being heard, not being, I guess, nurtured in their professional space. So I agree this happens all the time, a lot, very frequently.
So what about the difference maybe between, some people might see it as hazing and some people just think, oh, it's just a joke. We're just having fun. I mean, that's very common in the OR. You're new. We're going to send you out of the room to go find a pair of Otis elevators. And then we're all going to laugh when you leave because you go out looking for something that you don't know doesn't exist. I mean, it exists. It's an elevator in the hallway. But I mean, you don't know it's not an instrument. Where does it cross the line between having a good laugh because it's kind of what we've always done, but it's actually disruptive and it is bullying and hurting to these people that we're trying to bring into our culture and into the OR?
I think it absolutely crosses the line because, number one, you have not developed a relationship with that person in order to have that laugh or that joke or that relationship. It's not teasing. You're not helping them develop a skill. In fact, at that point, you could be actually putting your patient or other patients in the future at risk by not equipping this person with the skills that they need to do their job. So I strongly disagree with that whole dialogue. There's a difference if somebody, say I have a best friend, right, that works in the OR and they work on the CV thoracic team with me. And so I'm able to integrate a little bit easier into maybe that joking environment because I have someone who's nurturing me, who's saying like, oh, they're teasing, that's the elevator. And then you're invited to participate in that joke. Like, okay, well, I'll see you later. I'm taking 5 minutes. However, if you have someone there I'm just going to use the words like holding your hand through that, to me, I'm like, then you're inviting someone to participate in a group, you're collaborating almost with them in humor and relationship building versus this ostracizing, bullying, belittling. No one likes that. It's absolutely unacceptable.
Yeah, and I agree, Melanie. It is a fine line. I think the differentiator there is that when you are doing it at someone else's expense, that tends to cross the line in my head as going from humor to disruptive, really, in that environment.
And then you think about the patient on the table. Yeah, how distracting. That's not, that's 100%. Speaking of masks, right, in 2020, and people feel like they can't even communicate in the grocery store, let alone that's how you're communicating is you can speak, of course, with your words and with your eyes, but it's so distracting. Anything that takes away from the task at hand in the OR is a distraction.
So what are some of the forms? Like if you were to categorize, we had some examples that we all just gave there, but if you were to put them into categories, what kind of forms do they come in?
There's really 5 recognized categories of workplace violence. First is a threat to professional status or that public humiliation. That elevator was a great example. It can be in front of patients or colleagues, or say you're doing your pre-op assessment and their families in the room. Those things can be, of course, ultra damaging. So that's the first one. And then there's like a threat to personal standing or name calling, insults, degrading, teasing comments. There may be overworking or doing something impossible. Find the Otis elevator, absolutely doing something impossible. So the other thing is, you have to stay on call. So there can be just not giving someone incorrect information about their job requirements can be a part of that. Failing to give them credit or destabilization. So they had a great idea. They caught something. They did something. Somebody else takes credit and kind of runs with it. That can be a form of bullying. And then isolation, of course, not including them in information, even withholding. There's been research about even nurses or other staff members withholding information about a patient, their care or condition in order to essentially bully or make this person look bad. So all of these could just be, of course, radically detrimental to patient care and the environment.
Yeah, and I think you hit on a couple of items that are really important, and that's really regarding information control. It was referred to in the OR I worked in as being set up, either by your coworkers or by a physician. Talk to us a little bit about that and how that occurs.
Yeah, I have definitely heard and experienced this before. And I think that sometimes this setup can be intentional, and I think that other times it's unintentional. Of course, I would absolutely love to think that every time you have a setup situation, it's unintentional, but I know that that is not the world that we live in. But I also realize that the OR is an environment that can be very unhealthy. There's this idea that you want to be the one person, say you're the circulating nurse or the scrub nurse or a scrub tech. You want to be the one person in the room that knows what that particular surgeon needs more than anyone else. It's almost like a point of pride. Like we have this unique relationship or special bond and you don't. So if I scrub or circulate for them, they have better cases or just a better day. Whatever that is, there's some of that toxic culture in the operating room. So this person is training someone in or somebody else gets to scrub that day. They do that, sort of set them up by one of many means. Sometimes this is withholding information, or it can even be giving the wrong information to make that person look bad, which are both examples of things I've experienced working in the OR. One particular case, I was told by a more experienced scrub when setting up for a case, they use this retractor in every one of their cases. So when I pulled it out during the case, the surgeon was very upset, as you can imagine, we had the brief and we had the pick list, but it wasn't explicitly called out. So it was just kind of to make a fool of me or make themselves look better because they knew what they needed. And I'll go get that for you right now. Or I'll train her to, whatever that dialogue can be, kind of setting them up. That how could you not know that idea? Which I wish that I could communicate better with words, how deeply your heart just sinks and how embarrassed you feel. But even more concerning of all of these interactions of setting someone up that I think we don't talk about or maybe don't think about enough. If this is you and you're hearing this and you kind of do that to people sometimes to make yourself look better is that the trust and the teamwork of that entire room stops. It completely ceases and the care for that patient gets derailed. Everybody is distracted. And not only have you damaged that relationship of the person you have to work with now for a long time, but that patient on the table, I can't even imagine a more unsafe place for them to be. A worse feeling I can't imagine, or a worse setting for the patient. If that patient is me, if the patient is somebody that I love, that team as a whole is now derailed.
You're absolutely right. I mean, that feeling of just that, it's like this just gut bomb of, oh no, I don't have what they wanted. I was set up or all of this. And then you've got your surgeon sitting there looking at you and you feel unprepared. You don't feel ready. And then depending on their temperament, you might be in a whole new realm of being treated poorly, being yelled at, being thrown out of the room, all of these different things that can happen. How do we manage that relationship between the surgeon who is, the primary person responsible for this patient? Not that they're not our patient too, because they certainly are, but this surgeon has, and how they treat us. How do we make it an environment where we can work together to provide the best patient care without belittling staff or without making people feel like they're not adequate enough to be helping do the case?
Yeah, big answer. I think it's multiple interventions, right? From, I know every single OR nurse on this call has heard, I always do it the same way. And you just immediately roll your eyes. You're like, okay, just tell me what you need, right? Don't say I do it the same way. And so it's that. It's updating those pick lists on a personal level, of course. Then I kind of trained myself to be prepared. So I had the other one ready and not open. You train which is not the greatest intervention, but in the immediate need, you just do what you have to do. I think the other is we have to see who, those silent leaders that they're not going to, for whatever it is. I don't know if it's resilience. I don't know if it's confidence. I don't know what it is that they possess. I just try to be like them when I meet them more and more. But the silent leaders that don't get flustered, that just say, yep, I'm sorry, I opened the wrong one, and are able to not mirror the poor behavior that they're seeing or the cruelty of that. So encouraging that, buddying up with those people when you meet them and see them. And on top of that, I read something the other day that said, the moment that you don't, from a leadership perspective, the moment that you don't shut down poor behavior and the moment that you don't encourage good behavior, you've lost motivation for your team. So I don't mean to be rambling on. I just think it's so many little things that are going to come together. We have to give nurses in the operating room a sense of pride in their patient care, in their job, in their own career, in their own profession, instead of giving pride for how well they know another person's temperament or another person's caveats. Does that make sense? Yeah,
it does. And I heard two really strong themes that were coming out of that, which was, one is the humiliation piece, right? Is that's what Melanie was describing, that bottomless pit feeling in your stomach is because you've been humiliated, and nobody really performs well, in that mental state once you feel humiliated. At the same time, it's this like really odd rite of passage where you're testing them to see if they've got the thick enough skin to be able to handle when things get tough, right? So it's a weird little balance there, and it is a psychological game. And then the other thing related to escalation that I heard was, you were talking about surrounding yourself with somebody, who can kind of take the punch in a way when somebody is being inappropriate or loses their patience or responds to their stress, in an inappropriate way, and then not escalating that further by countering and pushing the buttons back. Like, okay, you want to fight today? I'm ready for a fight. And if you think about it, everybody that's in the middle of this procedure, high anxiety, tension, especially if things aren't going right. So the tendency, that fight or flight, that's what the test is. Who's a fighter and who's going to run away? Because we need fighters in here, right? And so it's almost like, there's actually, this parasympathetic chemical thing going on in your brain that people are responding to. And so having the strategies not to continue escalating it, and also, and I think you were making a really key point here, to not condone it is super important to a healthy culture in the OR.
Absolutely. And that I've heard that. And honestly, when I was trying to think through some of these themes, it does come to your mind. You're like, well, let me push them. Even if you have an altruistic mind of like, let me push you to see nursing is hard emotionally and in all the ways it challenges you to a degree that you sometimes can't even fathom when you see the repercussions of what happens in people's lives. But that's going to happen. It's not my job as a trainer or a colleague to push you. My job is to be your team, to be your colleague, to help you facilitate a solution, to help you create coping mechanisms or find really healthy coping for when you do encounter that, and to equip you for what I know you're going to face if I've been there already, not to push you so that you face ridicule and humiliation today. That, it doesn't make any sense. Bullying doesn't make any sense to toughen somebody else's skin for them, because it's not your job as their colleague.
Yeah, and the OR is unique in the fact that you have an environment where you have the surgeon, who's obviously, for lack of a better term, the captain of the ship. You have multi levels of education, experience, and so what do you do when that captain of the ship, that surgeon, is part of the problem or is the one causing the most disruption in the OR?
Certainly, my number one word is boundaries. Preferably in advance. If I did work with a surgeon like this, of course, not naming any names whatsoever, ever, but really cultivated that high school competitive, I'm cool and I'm in and you're not, room and space and boundaries, just like any unhealthy person in your life. You want to create those boundaries. What are you willing to tolerate and what are you not? How do you need to communicate those boundaries. So if that's happening in some of his cases, and I think I've come a lot farther in this space than when I worked there originally. So fortunately, that gave me great experience to practice setting some boundaries. But thinking about what's going to happen. So this particular surgeon would, even down to the music and making cutting, belittling comments. If you're not a bully, you're not going to fit in with the bullies. They're not just going to spontaneously like you unless you're playing the game and talking about other people too. So kind of expecting that in advance, communicating. It's really not appropriate that you're making these jokes right now. Fortunately, as the circulator, you're like, I have to turn the music off right now. I have to do something. So boundaries are very healthy and very important. And first and foremost, yes, your patient, but also yourself. Are you safe? Are you able to safely do your job and perform the functions of your job, assessment, all of that in this space? And if not, that needs to immediately get shut down, whether that's bringing in your manager, whatever you have to do, just not being afraid to make a big deal. If you really need help, if you need something right now, just like we would tell any family member, pull the code blue button if you're in trouble. If you're in serious trouble and you need everybody and their brother right now, you pull it. And I'm not saying do that in some of these bullying situations, but draw some attention to yourself. Get your manager, get the charge, get whoever you need to come in there and facilitate a safe environment. Get your buddy, who's the outspoken one. One of my older sisters is the most incredible example of this. She's just constantly, she's not afraid. She doesn't even think about it. She says, nope, I'm not going to let you talk to me like that. We'll either continue this or we're going to stop and someone else can come in. She is bold, which I love. And again, I try to emanate. If it's getting to that unsafe level, get yourself out of it, get that patient safe, reset the room with somebody that you know is able to tolerate, manage, and enforce those boundaries right away.
What about, though, when that person is a chronic offender? Nobody can work with this doc, or nobody can work with this particular scrub or circulator, whoever the person may be that is just hard to work with. How do we get administrative support, management support? How do we get them to support us when we really have a hard person to deal with? And then what if the person we're talking about is a surgeon who maybe is a high volume producer for the facility? So they're bringing in lots of cases and a lot of money. How do we fix the problem at that level?
I would say get objective. Start writing things down. Start documenting. Start trying to find anything that you can. I guarantee you, with a toxic culture in their operating room, they're not having great patient outcomes. And if they are, it's an anomaly, and that's good for them, I guess. But really starting to get objective. And my favorite of all is start looking for leadership roles that you can advance yourself into. If you have to get the job as the manager to make the change, do it. If you have to go head up, and this sounds manipulative, but it's not, get to know the administrator whose office is outside of the OR in the hallway. If you have to call HR and continue to report things, and do whatever you have to do, again, get objective, start documenting, get other people to start documenting. Whoever their head of surgery is, if they need to get involved, it's not okay. And it's not just one of those things where like, oh, well, I guess we just have to deal with it because so-and-so, which is an easy solution, but it's not helpful to anyone. And we do see negative patient outcomes. And I mean, nurse suicide. There's all these things that are already at play here. It is a serious enough thing. You're not just going to be the one who's like being annoying and complaining. It's a real deal. We have objective evidence that this is detrimental to staff and patients. We have a lot of it in the research world.
Yeah, and it's got to impact staff turnover as well in the OR.
Absolutely. And I don't know what the most recent number is for like training a new nurse in the operating room. Man, it's like the last one that I saw, which I think is old, was like $60,000 to train a professional nurse in the operating room.
That's low.
Yeah, that I know. It was probably like 5 years ago. I better check.
No, I'm just saying it's a low estimate. It doesn't really, you know what I mean? Like, even if that's the number now, it's a low estimate. It costs way more than that. There's no way there's a lot of soft costs that aren't being included in that.
Yep, absolutely. I just don't support the idea that bullies should win. I think that you need to do whatever you need to do. You know, if you have to hire someone or ask your friend who does something else to create a PowerPoint for your manager to say, here's what happens when you have a toxic, say it is the surgeon in this environment. Here's what's happening to our patients. Here's what's going to happen. You think they're making all this money, but here is what we can see long term when we chart these things out. The other thing is just really, it's going to take your whole team. So really knowing, I'm going to use our CV thoracic team, which is mostly super great. That one person in the room does not get to behave that way when the scrub or the circulator, whichever one I am, when we've level set that's not going to work. That's not appropriate. It doesn't happen. You have an anesthesiologist, a CRNA, you have other people in that room that if you can level set, they're not going to get away with it. You can't kick out every single OR nurse and scrub tech and CRNA on the team and be able to do surgery. You can't.
I have another question for you, kind of related to the attitude and the environment in the OR. If you ask most people in the OR, what advice would you give to a new person coming to the operating room? A lot of times they're going to say, grow a thick skin and don't ever let anybody see you cry. I mean, that comes off the tongue so quick with so many people. If you could change the environment and change the culture, what would you change it to? What would our advice be to new people instead of that negative advice? What would it be?
I think my hot button word of the year, personally and professionally, has been the word resilience. I have a love-hate relationship. The same sister who's like that strong advocate, she's actually a psychologist and a counselor. And so when we were talking, I said, I literally hate the word resilience right now because it's being used for nurses in these situations, right, where they have no advocates and they're kind of left out to just deal with it or just go and cry in the break room because you're not supposed to cry in front of anyone. That's how resilience is taught in the culture. But that's not the true definition of resilience at all. In fact, it's that like strength to be able to set boundaries and enforce them with, even if you're crying, that's okay. With confidence. So I think that I would change that dialogue to develop true resilience. Being able to constantly deliver patient-centered care, deliver yourself patience and grace, as well as set healthy boundaries.
That's good.
All right, Michelle. Yeah, really, really good job on this interview. It's a tough topic too, right? Because this is kind of one of those things that falls into that category of, but this is the way we've always done it. And, that normalizing of that behavior, there's going to be lots of people that are going to listen to this episode and aren't necessarily going to agree with everything that we said. I think your passion, and your knowledge on the subject came through, and you can tell that we all agree with you 100%, but there are going to be some people who are going to listen to this and say, no, you know what? I grew up in a tough culture and that's the right way. And, it's brave and resilient, to be able to come out and say, okay, here's where the boundaries are. Here's where the lines should be. And I think you did a really good job of that today. And I just want to thank you for coming on and being bold and brave enough to really take this topic head on.
Yeah, sure. Can I add one thing?
Absolutely.
There's one now that I'm thinking, and then I'll stop, is eliminating the finality of having that suggestion, right? Like the suggestion currently even being develop thick skin, don't let anybody see you cry. It's not the end. We can, that will manipulate and change over time. So then I say develop resilience, and then next year, through collaboration of all the generations and types of people that work in the workplace, that changes and morphs to be what is needed at that time. There's no finality in our lives really until death. So we should constantly be evolving, educating together.
Well, We may be at the end of the interview, but it's also not final because I could tell we're going to have you on again in the future. We will have you back for another season. You did a fantastic job. So once again, thank you so much.
Yeah, thank you all.
That was Michelle Lemmons, clinical educator at Key Surgical. And Melanie, this is such a good one. I mean, we talk about culture is king, culture in the OR. Jeremy even brought up, what's the impact on staff turnover? And Michelle mentioned that, hiring and training a new OR nurse is probably at least 60,000, although she thought that stat was a little bit older. And I definitely think it's higher. And, employee retention is so key. And, this whole testing of the thickness of the skin, it really can have a pretty big impact on how well the OR functions. And so I just thought it was a great interview, a great topic. And she's obviously done quite a bit of research on it as well.
Oh, absolutely. She really hit on some key points on how we need to change our culture and think about the way that our actions really do affect the other person. When we're playing that joke about the Otis elevator, we think it's funny, but it completely distracts this person, maybe humiliates them. And then ultimately we have distracted from our patient care. And our main goal ultimately in the OR is patient safety and providing the best patient care that we can. So when helping to remember even the things that we think are funny can have a detrimental effect, can help us change that culture for the good.
Yeah, that whole concept of having a rapport is really important, is always remembering that you need to have a rapport with your coworkers. And part of that is how you bring them into your work environment. It sets the tone and establishes that rapport. But that's going to do it for this week's show. As a reminder, you can support us by subscribing to First Case on iTunes, Stitcher, Google Play, and Spotify. We'd certainly appreciate a rating and a review because your feedback is important to the show. And on behalf of Melanie and Jeremy and myself, thank you for listening to this episode of First Case.